The whole point of this evening was really triggered by this document. Have any of you seen this? One hand, solitary, and a couple of yeses. This is the NICE guideline for investigating chest pain of recent onset. And it covers recent onset stable angina, and it covers recent onset acute coronary syndromes. It is well worth delving into and having a look through. For example, I'm just going to quote you from page 5. Do not use exercise ECG to diagnose or exclude stable angina for people without known coronary artery disease. Did any of you know that exercise testing is no longer considered to be a diagnostic test for angina? There are quite a few changes like that this document proposes, and they are founded on the fact that we don't need to guess anymore what's happening in the coronary arteries. Changes in technology have fundamentally transformed our ability to look at the coronaries and see what they're doing. And the implications of that will go through as the evening goes on. It's quite a hard-hitting program, and it starts with a very hard hit, because until you understand the technology, the rest of what we're trying to do doesn't make as much sense. And I'm delighted that we have with us Mr. Hank de Vries, who is the European Head Product Manager for CT, with a special interest in cardiology and dosage. And I shall hand over.
Thank you for the introduction. Okay, that's mine. Thank you for giving me the opportunity to give a brief presentation on technical developments. I will try to keep it as simple as possible, but technical always includes some graphs and drawings and things like that. Basically, what we have today in cardiac scanning, there are two different approaches. There's the helical approach, and there's the so-called volume approach. The difference between both is that in the helical approach, during scanning, the gantry will move over the patient. In a volume approach, there will be no movement at all. The latest technology in helical scanning is the so-called high-pitch helical. In the past, you had normal helical, which would take about, let's say, 10 seconds to scan a heart. With a high-pitch helical, you can do it within a beat. And this also states is because of technical improvements in computer tomography, this technology has become increasingly reliable. And the better temporal resolution that you get with a high-pitch helical makes the image quality less dependent on heart rate, but also less dependent on the phase of cardiac cycle. And this scan mode enables complete image acquisition with associated very low dose exposure. And if we talk about very low radiation, we'll talk about sub-millisievert scanning. The volume approach is totally different. There's no movement of the gantry, so that means that the system should cover the heart in a single rotation. And what we have nowadays is a so-called 320 row scanner or 320 slice CT scanner, and it can image the whole heart. And this new technique could be useful to also do non-invasive modality for investigating subjects with chronic atrial fibrillation. And this is a total new area. So just comparing, I said we have different scanners in the market. One is using a helical and moving during scanning. That's the one you see. See if this laser pointer works. The one you see over here, it only has a coverage of maximum of 40 millimeter, which is not enough to cover the heart, so it has to move over the heart to cover the complete length of the heart. Then in between there's an 80 millimeter coverage, and the one with the widest coverage can cover up to 16 centimeters, which is enough to cover the heart without any movement of the system. Different technologies are used. This technology is used for the high-pitch helical scan. This technology is used for the axial volume. And this is an in-between which does not use a high-pitch helical and which does not use a single volume. So I will skip that one later. One of my previous slides showed that scan modes enable complete image acquisition within one cardiac cycle with associated low radiation exposure. So I told you already, there are only two ways to do a one beat or single beat scan. That's a high pitch helical, and that's the actual volume. And I will focus on these two technologies. I will skip this in between one. For the helical approach, where the system is moving over the patient, it is stated the heart rate must be low, so there's a long enough diastole to accommodate the data acquisition. You have to acquire the heart, and you have it in such a way that you can reconstruct it in a non-moving image. And this is from the paper from Stefan Achenbach, one of the most famous users of cardiac scanning. Now, what I said, you have to scan in the diastolic phase. If you have the R to R peak over here, then the diastolic phase is usually in this area. Let's say from 70% till 90% of the beat you can make your scan. So everything has to happen in this time frame. And when you have a moving gantry, you can make one slide. It's one image, actual image, like you cut through the body. You can make a second one, a third one, and you can make them all. But all these will have, as you see in the R peak here, a slightly offset in time. So they're not all acquired and reconstructed in the same phase. So you hope that from here to here there's no movement, and that you would have one data set where you can go from top to bottom and there's no movement between the slides. Although there is a small time difference between them. In a volume scan, you just make a single rotation and you're ready. There's no movement at all. Which means that if we looked at the same image, I would use the same length of time, which is usually around 350 milliseconds. I can do a single rotation, and I can reconstruct exactly, for example, here at the 75% phase of the RR peak. However, you all know that the cardiac motion is not always centered with, let's say, no motion around 75%. It could be earlier or it could be a little bit later. Patients are different, they're not robotics. So what you can do with this single technology, and because you cover the whole heart, you can even reconstruct in a different phase. It's a single rotation. You can reconstruct, for example, a little bit earlier or a little bit later in the cardiac phase. And you still have all the images in exactly the same time frame. Now, what is the big advantage? Using the high-pitch helical, as I showed you this image, you can only make one scan, a so-called prospective scan. You start scanning here, you stop scanning there, and you can reconstruct what you have, and there's no way of flexibility. If you go to a single volume scan, like on the Aquilium 1, you can have the same length of acquisition time, but you can reconstruct different phases, and you have the whole heart. And you cannot compare this part. If you only take half of this one, you also have only half of the heart, because the heart is not completely covered. Now, why is it so important? If we look to these examples, single rotation volume, reconstructions at different time frames, we see here very early in the exposure, the image looks relatively nice. This a little bit later, it looks also nice, but the small movements over here. This is exactly in the center, it looks a little bit better, but here you see around 80% of the face, you have by far the sharpest image. And this freedom you have when you do a single rotation. This freedom you do not have when you do a high helical, because you will start over here and you will end over here. And all the movement is in between. So also this little movement, but you never get exactly to this face, only for one or two slices. The images you see here do not show any movement artifact. Doing a single rotation, you can go to what's nowadays a very hot topic, the so-called sub-millisievert scanning. And sub-millisievert is everything below 1. So this is even below half a millisievert. Shows you very nice the example here of the different coronary arteries, including calcifications, a 3D for orientation, an axial slice, which is mostly used by the radiologists. They will go from top to bottom to judge all the images. And these are so-called MPRs, multiplanar reconstructions, or curved, where you can go a reconstruction exactly through the artery. This is another example, also 0.5 millisieverts, also scanned on an Aquilium 1. So very low dose scanning here is possible if you look to the coronary arteries. Then there's another difference which might be very important. Very often you see in the coronary arteries calcification, what you see over here. And if you have a movement during scanning, you will have some so-called blurring. The image is not exactly sharp. And if you look to the 320 row and you compare this one to this one, it's exactly the same patient scanned on in two different ways. Here you see more calcification than you see on this side, which might be very important for your diagnosis. So as I said, we have the comparison between a single beat and a single rotation. The single beat on the high helical pitch, where you do in a single beat this reconstruction, and a single rotation on a volume scanner. What happens if you do a single beat on a volume scanner? Then the image would be totally different, because if you do a single beat on a volume scanner, you can still use very low dose. You start at the R peak and you end at the R peak, which means you can reconstruct diastolic or systolic phase. You can even reconstruct the full range and do an ejection fraction, for example, which would give you extra information. This, in a single beat, is not possible in a helical approach. And in case you are interested in this, of course, it's very important if you do this in a single beat, and I will show you later why. What you see here is a loop of all the reconstruction in the face. And this is a so-called short axis, and you see the heart beating without any artifacts. But this basically is just a 1 second scan without movement of the gantry. Let's see if we can go to the next one. Do I have a keyboard? Something down here. There we go. As I said, from this single beat, you can calculate ejection fraction, cardiac output, everything extra on top of coronaries only. If we go back to the helical approach, the high-pitch helical approach, it's also stated that heart rate must be regular. And that is very nice if you have all patients with 60 beats per minute or 55 beats per minute and there's no variation. But there are many patients in the population coming for cardiac scanning will have irregular heart rate or will have a higher heart rate. And how can we approach that one? Now let's say the so-called prospective scan setup. Prospective means that before you start scanning, you already define what you want to scan. And you give a command to the scanner and you say, okay, if I have R peaks like this with, let's say, 60 beats per minute, I just want to scan this small area within the R peak to keep it as short as possible, to keep the dose as low as possible, and I'm only interested in the coronary arteries, so only in the diastolic phase. I'm not interested in systolic. I don't want to do an ejection fraction. Now, if we compare the two technologies, here we have the helical. This is the so-called onset. This is the start of the scan. The first, or the image will basically be made in the third beat. With a volume scanner, because there's no movement, direct after the onset, you can make your scan. The time between this one and this one is mandatory, because the table, which cannot be accelerated in a very short time, has to be set in motion before you actually make the scan. So you need a trigger to start the movement, and then at a certain amount, a certain period in time, you're over the heart and you make your scan. Looks like this. This is where my scan starts. My table starts to move. Over here, I'm at the right position, at the right time of the peak, and I make my scan.